Well, welcome to our webinar tonight with Optometric Education Consultants. Tonight's topic is OCT and OCT Angiography in Retinal Disease. And it's my distinct pleasure to welcome and introduce our speaker, my partner and friend, Dr. Greg Caldwell, who is a 1995 graduate of the Pennsylvania College of Optometry. He also completed a one-year residency in primary care and ocular disease at the Eye Institute. He's a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry and a fellow of the Optometric Glaucoma Society. He currently works in Duncansville and Johnstown, Pennsylvania as an ocular disease consultant in private practice. His primary focus is diagnosis and management of anterior segment and posterior segment ocular disease. And he's been a participant in numerous FDA clinical investigations. He's lectured extensively throughout the country and internationally. In 2010, he has served as president of the Pennsylvania Optometric Association and has served on the AOA Board of Trustees from 2013 through 2016. He is president of the Blair Clearfield Association for the Blind. So with that, please join me in giving a virtual round of applause to Dr. Greg Caldwell.
And thanks, Joe, and thanks for that nice, robust introduction. And for this topic here, everyone, OCT and OCT angiography in retinal disease, we're just going to scratch the tip of the iceberg here. You know, this could be easily 6-8 hours of lecture, and luckily tonight it's not. But we'll pick some cool stuff to look at on OCT and angiography and kind of get everyone feeling comfortable with it. So disclosures, that was a quick disclosure. Disclosures, I'm going to mention many products and instruments and companies during this discussion. I don't have any financial interest in any of these products or instruments. And more importantly, these companies have not influenced how I'm going to speak upon this topic. However, I do want to point out that I have in the past lectured with OptiView or for OptiView, received honorariums. I use this instrument in my practice. A lot of the concepts that I teach tonight can be used in other OCTs. So again, nothing is influenced and I have no financial interest out there. I am the PA medical director for Involve and I am half owner of Optometric Education Consultants. We do 5 live meetings. We're going to do 4 this year. And I am half owner with Dr. Joe, who just did a nice introduction. Thanks again, Joe. With that being said, I'm going to just start off with a couple resources. This is something that Julie Rodman and I started last year when OCT Angiography came out. It's on OD. It's on Facebook. It's similar to OD on Facebook, but this is something that we did. It's called OCT Connect. We have no financial interest. We have no advertisers with it, so on and so forth. We're up to about 6,000 people. It started off just for being OCT angiography, but now it's it's basically everything OCT, and it's kind of cool. It's international. I mean, we've got people from pretty much all across the world here, from Singapore to Australia to Europe to Israel and Asia countries. So it's just pretty cool. So you could post it and OCTs or just go through and scroll, and lots of good images there. Regarding books, this one here, Atlas of Retinal OCT, by Darren Goldman, Wahid, and Duker. Anytime you see those names, that's kind of your traditional B scan. And then Julie Rodman, again, I have no financial interest in here, but here's a good book on OCT angiography and how to interpret those. So, you know, the OCT, it's very complex in how it works. And luckily I got a great technician, and how this coherent light and, you know, hypo and hyper reflectance. And this is kind of how I look at it is, you know, then a miracle occurs and, you know, you get the outcome over here. You know, you need to be a little bit more explicit here in step 2. I'm really not sure how these work. In a sense on this side, but I could tell you, yeah, I know how to interpret them pretty well, and that's really what we want to kind of talk about tonight. So with that being said, you know, OCT and OCT angiography, both are becoming equally important: diagnosis, management, and treatment. And that has led me to my next my next polling. I thought the polling question was coming up here. Sorry. I thought the polling question was coming up. Sorry. It's coming up, Joe. You've been warned. So with that being said, optical coherence tomography. Time domain is about 15 to 16 microns of resolution. The stratus is, if you remember then, that's 15 to 16 microns. Spectral domain is 5 to 6 microns. Now, let me kind of bring this to life because I say this to the patients all day, almost every day, because we have a pretty good wellness program in our practice. We're looking at OCTs all the time. So I say to the patient, this is really, really cool. An OCT can see 5 to 6 microns of resolution. That doesn't really mean much to the patient. We really don't work in the metric unit as a society. We do as in medicine. So I always say to them, I say, it's like taking a slice of bologna, which is a millimeter, sending it back to the delicatessen and saying, hey, can you please cut that 1,000 more times for me? They all can relate to that, and that's pretty thin. And if you would just take 5 or 6 of those slices, you take a millimeter, cut it 1,000 times, 5 or 6 of slices, that's all the bigger it has to be to be able to be picked up with optical coherence tomography. So, some of the SWEP sources are getting down to 1 micron, but then we're kind of losing some resolution based on, so it's kind of cool. They're going to get it all figured out, but we can see a lot with these instruments. So images in retina microvascular without the dye and injection, that's the next chapter, and we're going to touch on that tonight. So if you think about time domain, which is this picture down here in 2002, it was pretty cool to be able to see some of these structures and see what's going on. And then quickly in 2006, spectral domain came out with more scans per second is what the key is, and then getting cubes of data rather than being extrapolated and getting these beautiful pictures. And then in 2014, OCT Angiography came out. And again, I'm going to mention here that a lot of people are saying, well, which one is it? Should I do angiography or should I do B-scan? I call these B-scan angiographies, and this is just your OCT angiography. The key here is that, a lot of people say, which one is it? It's like a 78 or 90. Well, you kind of need both, right? 90 is a little wider field, 78 or 60 gives you a little bit better depth of perception, but it narrows down your field. So I kind of have both in my office, and I use those 90s and 78s, but I also have the B-scan and the angiography. I'm going to bet if you have an OCT in your office, at some day you're going to transition into angiography because you get lots of great data, and it can really help solve some mysteries and really help in the diabetic and the macular degeneration patient. So kind of the 4 basic categories of disease that I look at is it's kind of choroid and sclera. And then we're going to look down here into this, into the outer retina region, and then the inner retinal region and the vitreous. So that's kind of like the 4 layers of how an OCT will kind of pan out: choroid, RP, neurosensory retina, and vitreous. Now, what's really cool is I even found some really cool anatomy, and I'm going to turn it into and add it to my lecture. But we look at the RPE complex here, and then we look at the outer segment, and then what we call the inner segment, and then the external limiting membrane. And then we have the nuclear layer, which is hyporeflective, and then the plexiform layer, and then nuclear layer, and again, a plexiform layer, and then the ganglion cell and the nerve fiber layer. But what I really want to focus on, or where I've kind of going to turn into maybe a little bit more of a geekier lecture at some point, is really focusing on these layers. And once we find where the external limiting membrane is, I was just reading maybe a few months ago and found out we always talk about the inner and outer segments, but this layer in here is called the myoid layer, and that's a part of the photoreceptor, MYOID, the myoid layer. That's kind of like your Golgi apparatus and some of the fluids hanging out here. And then this one has kind of been named the ellipsoid zone. And a lot of people think the ellipsoid zone is kind of this area because of ellipsoidal shape. But it's actually, this is the inner segment, now termed the ellipsoid zone. Let me just tell you the importance of that. Why is that light up hyper? That is nothing more than tightly packed mitochondria. And remember, the mitochondria are the powerhouses. And as we start looking at some retinal diseases tonight, when these mitochondria are starting to die or go dormant, that's whenever we really start getting concerned about how the retina is being stressed, either from diabetes, or is it from something from the inner or outer retina, or is it something from macular degeneration? And then, so this is the ellipsoid zone. So that would be the inner segment. And then the outer segment is this zone right here. And then we get down to this RPE complex. And I really like this scan because they call this the interdigitation zone right here. When you can see this RPE complex, this dark area, doesn't show up in all the scans. And as you can see here, it becomes one of a single color. And right here, what's happening, this is where the photoreceptors are coming into the apex of the photoreceptors coming in contact with the base, with the RPE. And then down here is your RPE and choriocapillaris. This area is nothing more than the photoreceptors is what it comes down to. Think about for photoreceptors from here, that myoid zone, the ellipsoid zone, the outer segment, getting to where the tips of the photoreceptors are, and then to the RPE Brooks membrane. This is really where you can really predict some acuities that are out there. And then again, this is just another area. Again, the ellipsoid zone, the epiretinal membrane, the external limiting membrane right here, the myoid zone, the mitochondria, the ellipsoid zone, the outer segments, and then you're starting to get into that interdigitation zone and the RPE complex. And then you can see all the other layers that are still there. So that's kind of what I call the traditional B scan. And now what we're getting with these new OCTs is being able to do angiography and looking in the inner retina up here in this area here at the superficial capillary plexus. A little bit deeper below that superficial capillary plexus is the deep plexus, moving out into the outer retina where those photoreceptors are, where I just beat you guys to death with myoid and ellipsoid and all those different zones. Really, no blood vessels should be there, right? Those photoreceptors need to be clear to be able to capture that image and process that high acuity if they're in line and not being stressed. So no blood vessels out there. There's plenty of deep plexus to give them nourishment. The choriocapillaris, that's areas microns thin or thick, whichever way you want to look at it. So no blood vessels out there. And then you have the choriocapillaris. And this is all done because you're able to scan at 70,000 scans per second. And I'll talk about that when we get there. So when we look at a normal patient here, a 25-year-old, I don't want to get too deep into OCT and A interpretation, but these are just some of the scans that we can do. And these are percentage right here of the radial peripapillary capillaries. It's a percent. And I look at these all day long, and it's about 50 to 60% when the patient's healthy. And we get a nerve fiber layer scan here, nerve fiber layer scan here, and an inferior here. And this is just beautiful, healthy, robust. Whoever would have thought that you could use angiography in glaucoma? So where I find angiography very useful is you'll see here patients with diabetes, patients with macular degeneration, and now glaucoma. It's another structural test that we can do. And another area over here is, where the ganglion cell complex is. We can see how the macula is functioning. So these are just different scans that you can pick up on the optic nerve or the angio disc. Here's a retina scan, again, looking at superficial, deep, the outer retina, no blood vessels, and then this choriocapillaris, and picking up density, seeing what's happened to these capillaries. I will point out here, as you can see, red is blood flow. So there's kind of your superficial plexus, your deep plexus. Nice. You want to see that red, blood's flowing through there. You can see now nice and active your choriocapillaris is, and then you can see this outer retina is free of any blood flow. And this is exactly what it should look like when you have someone that's nice and healthy. So does it change when someone is 60 years old? Well, not really. This is my partner in the practice, takes really good care of himself, has a good diet, exercises, so on and so forth. And you could see nice, healthy radial peripapillary capillary density, superior, inferior, nice nerve fiber layer thickness. This is another nerve fiber layer. You can see what the scans look like. Come over here, look at his retina scan. You can see he has a little bit of a vitreomacular adhesion. We'll talk about that here shortly at 60 years old. And you can see here that his macular capillary density looks really, really healthy. So just kind of showing you that, that what normal looks like. And you can actually measure. One of the nice things, again, I have no financial interest over OptiView, and I have to check with Zeiss and Chopcon and Heidelberg since the COVID periods. But prior to COVID, they really weren't able to give you a number. It was just kind of looking at the scans, and that's how OptiView was prior to. And it was very hard to interpret. So having these numbers and being able to measure, to me, in angiography is extremely important. And I just need to check with the other companies because I know that they were looking at it, but then with COVID, and it has to be FDA approved, they're trying to get lots of treatments approved over there, and it's pushing back some of the technologies. Obviously, we have to focus on COVID, and I'm not bashing that, but it's just slowing down the process of getting some other instrumentations approved. So you can take and montage these images, which is really, really cool. Here's the optic nerve. Here's the retina. You could just see how these capillaries just pan out, which really makes this kind of scan important in maybe glaucoma and in diabetes, and then looking at the vasculature for macular degeneration for the other scans down at the choroid level. So this is, again, just what a normal scan would look like. You can kind of see right in here, this RPE complex is kind of separating out. And again, your outer segments. And then I always like looking at really closely these mitochondria, that inner segment. There's lots of names for them, so I'm just going to keep repeating them. Inner segment, that ellipsoid zone, because those are the mitochondria. And even here, it might be a little kind of scary. Is this a disease process? What's going on here? Looks like, or is it just a low quality scan? Because they're starting to become maybe a little not as robust in highlights there. But with that being said, you can learn to predict acuities. I wouldn't expect this acuity in this area based on from the external limiting membrane, that myoid zone, the ellipsoid zone, that outer segment, and then how this is looking down here at this RPE complex. This could be, unless there's a cataract, this patient should be 20/20 or better, right? So this is where you want to look. And I'm going to show you some scans tonight where there's some epiretinal membranes, and this retina is really, really thick. And you can see that as long as that photoreceptors are intact, you're going to have some pretty good acuities there. So out the OCT of vitreoretinal interface disorders. So, Joe, I thought it was earlier. I apologize. Here's my first polling question of the night. So everyone pay attention. Make sure that screen is shrunk down. What I want to just kind of know is, where's everyone sitting in their office? Do you have an OCT? Are you doing OCT angiography? Or there's no OCT instrument at this time? Just kind of curious.
The poll has been launched. And right now it looks like OCT is ahead at 60%. OCT and OCT angiography is at about 17%. And no OCT at this time is polling around 25%.
Yeah, that's kind of, whenever we do our loose hand polls, when we do live meetings and you have people raise their hand, it's usually now about 70 to 80% of the optometrists have OCT. And then there's, a handful whenever I ask, okay, those who have OCT, how many have angiography? And again, of those, it's, usually about that 10 or 20% raise their hand. So, that's why we're here tonight, to kind of learn how to interpret these, how to use them in our practice. For those who don't have them, maybe this will maybe spark something to bring in your practice if you find it to be useful. So where I want to kind of start out, again, this could be a 6-8 hour lecture on retina. We could do AMD at a very deep level. I would hold 2-hour lecture on that, right? But let's just talk about where I see the OCT really helping me out in the practice. And it's really in this vitreoretinal interface disorders. And there's been a little bit of naming change coming up here, and I'm going to show you where that came from. And if you guys want to email me, I didn't have it as a handout in there. I just thought of it now. I have the paper downloaded, or you can look the paper up. on PubMed. But there's been a little bit of nomenclature change. So if you're a little bit older, you might call things stage 1, stage 2 macular holes, and there's been a little bit of a change. But there's epiretinal membranes, there's vitreomacular adhesions. And the cool thing about the vitreomacular adhesion is we have a full, complete vitreomacular adhesion from birth. Basically, that's just your posterior vitreous up against your retina. But then when I showed you in my partner, when it starts to lift up, we're able to see it, and it's more kind of a focal or a broad vitreomacular adhesion. So one of the numbers that you're kind of going to learn from tonight is 1,500 microns. If it's 1,500 microns or less, then we would consider that a focal vitreomacular adhesion. We all have a broad one, right? Because it's greater than 1,500, and then as we start seeing them, they become visible. It's either focal or broad, and this can kind of help predict what's going to happen. Same thing in vitreomacular traction, and then we have pseudoholes, lamellar holes, and full thickness macular holes. So epiretinal membranes, what I kind of want to focus on is, I like asking the audience when we do these live presentations is, where does this epiretinal membrane come from? Does it come from the vitreous? Like, how does it start to form? Why is it in some people and not in the others? So usually what you need to do to have an epiretinal membrane is you have to have a break on the internally limiting membrane. And it's usually from a PVD, right? So someone has a PVD, you see them, you diagnose them, you see them back, you're checking for holes, tears in the periphery. And then, you say, come back for your yearly exam, maybe after you see them once or twice to make sure that they don't have a horseshoe tear, they're leading to a detachment. Then you see them back a year or two later, and then they have an epiretinal membrane. Well, what happens is you get this break in the internally limiting membrane, and then in this neurosensory retina, there are cells, astrocytes, glia cells, that are trapped in there, and they're able to leak through that crack and grow across the surface. And then it all depends now what happens, whether the posterior vitreous is still nearby, whether it attaches itself to the posterior vitreous, grows across, and the posterior vitreous is far enough. And then as the membrane matures, it kind of contracts on itself. So literally where this membrane comes from are from these cells that are trapped in the neurosensory retina. So this is just a very classic case of an epiretinal membrane that has come into the practice. You can see the epiretinal membrane has grown across the surface. It's still attached itself, in a sense, to the posterior vitreous. And now that retina is becoming accordion-like. And you can see some fluid right here and some fluid up in this area. And then we definitely see some fluid here and some cystic areas. Now, this retina is pretty thick. And when you look at the number, you're going to see, as we look at these, and I look at them all day long, that foveal pit could probably be as low as 240. That's kind of a low end, 250, 260. This one's 473, almost double. 500 would be, double. So 437, a very thick macula. But this patient probably has really good acuity, because if you come down here to that ellipsoid zone, or that inner segment, right, the black area here, that hyporeflective area, that's the outer segment. But this is all intact. I would bet if you refracted this patient and they don't have a cataract, and you forced them to read the Snellen eye chart, I bet you they could be 20/20. Maybe 20/20 missing a couple, because this whole area is intact. And I say Snellen because if you would check it maybe on contrast sensitivity, that would drop way down. The Snellen acuity's kind of got some big steps in there, 20/25, 20/30. But I bet this patient would read 20/20 visual acuity on this. And this is what it looks like on the en-face. You can see right here is the macula. You can see this is where a little bit of traction is occurring. You can just see how this is being stretched right across the retina here, and then there's just some traction. Joe, it sounds like you want to say something?
Yeah, Greg, you had mentioned some of the cells that they have found in the epiretinal membrane, and one thing that I didn't catch was, and nobody has an explanation for that. They've actually found RPE cells in epiretinal membranes. Did you mention that?
I did not mention it, but that's part of the process, yes.
Yeah, but nobody has an adequate explanation as to why RPE cells are there because of the great distance. So there are some curiosities about epiretinal membranes that we just don't really fully understand just yet.
So the other part of that too, which leads me into, if you ever had someone that had a horseshoe tear, and then they went for retinal detachment surgery, and they ended up with proliferative vitreoretinopathy, PVR, right? Not PDR, not proliferative diabetic retinopathy. This is proliferative vitreoretinopathy. And so what happens in a full thickness, like horseshoe tear, you do have a tear, so those astrocytes and glial cells can leak out. But now you have the RPE exposed. So those cells are now going into the vitreal cavity. This is the bane of retinal detachment surgery, right? They go in, they do the buckle, they put the retina back on, the retina's looking great, patients, healing well, and all of a sudden 6-8 weeks later, you see them back, and it just looks like something's grabbed that retina and it's created that star appearance pulling off. That's PVR. And PVR it's really aggressive because of these RPE cells that are found in there. So I understand that PVR can have, Joe, then that's a very supersonic, if you want to say, epiretinal membrane. But yeah, that's kind of neat that, epiretinal membranes like this can have RPE cells. I guess we can say it's a far way to travel, but again, it's only kind of a couple hundred microns. But PVR definitely has RPE cells, and epiretinal membranes, that's kind of cool that they have RPE cells. So here's another one here. You can see on this scan down here, if you guys follow my pointer, there's the optic nerve. This right here is just another big PVD. This PVD is what's cracked the internal limiting membrane. And this really makes sense to the patient when I show them these enfos and how this extra scar tissue, for lack of a better term, is growing across the surface. And then that's the concern. Is it going to turn into a full thickness macular hole? Is it attached to the posterior vitreous to create a posterior, like a vitreomacular traction, that type of appearance? And that's why we follow these patients and image them and just make sure that there's nothing bad that's happening over time. Here's a raster scan, and you can kind of see what's happening here. This patient would have very good acuity, even though you have this distorted macular appearance. This membrane's kind of contracting on itself. There's fluid in this area that's filled in this space. You can kind of see what's happening, how this retina is kind of being puckered up. But again, the acuity on this patient would just be really, really good. And this is just another scan, again, of an epiretinal membrane. Again, looking at the macula area from the external limiting membrane to that ellipsoid or inner segment, outer segment, to that RPE complex. Again, I would not expect on Snellen acuity, on contrast sensitivity, that could be different. But on Snellen acuity, this patient should be 20/20 in refraction. And look right here. What do you see right here? You can see the PVD that has created all of this, in a sense, by cracking that internal limiting membrane. Joe, any questions come in before I start talking about the International Vitreomacular Traction Study Group?
I'm looking now, and the answer is no.
Great. So everyone that's out there, I do have this paper, and I apologize that I didn't get it sent as a handout. You can email me. It's thegrubod@gmail. But this isn't anything that's new, like 7 years old in a sense. This paper came out in 2013. Now, 2013 and beyond, I started getting letters from the retinologists that were, hey, vitreomacular adhesion and traction, and it's focal and broad. And then they changed kind of the names of stage 1, stage 2 macular holes. This is the paper that kind of changed where some of that terminology has come from. So this is a nice paper. It's a pretty easy read. If you read through it a couple times, there might be some new words that you come up on and some new terminologies, but using tonight's lecture and using this paper should help you out. So, they started to define vitreomacular adhesion is defined as this perifoveal vitreous separation. Vitreomacular traction is characterized by anomalous posterior vitreous accompanied by anatomical distortion of the fovea. And then there was this focal and broad at this 1,500 microns. Really easy for you to measure this because if you remember, optic nerves, there could be macro discs and micro discs, but on average, an optic nerve is about 1.5 or 1,500 microns wide. So in these wide field scans, you can capture the optic nerve and you'll kind of learn what 1,500 microns is so that when you're looking at these scans, or remember that just outside the fovea, when you start looking at them, they're about 340 microns, 260 microns at the foveal pit. You can kind of use that and measure. And a lot of these instruments do have measurements, and you'll see how I do that on some of these scans. But that's when we're talking about, focal or broad. Focal's kind of like a high heel walking on snow that you can kind of puncture through, so a little bit higher risk. And that's why they talk about focal and broad. So when you're looking at vitreomacular adhesions, everyone out there, myself, Joe, who's listening here and being my eyes and ears, we all have vitreomacular adhesion. It's broad. And as we get older and start seeing them, it might turn into a focal. So you'll see it here as you classify them as focal or broad, depending. Now, the vitreomacular adhesions, they're the kind of we see those all day long. It's when you start getting into the vitreomacular traction is when you start getting that perifoveal detachment. You start getting distortions to the retina. And those are the ones that can lead now until what's just cut off down here. What's coming up is the full thickness macular holes that are out there. So the vitreomacular adhesion is equivalent of a stage 1 PVD. Most eyes have a complete vitreomacular adhesion from birth, right? And that's what I keep saying, that posterior vitreous is attached to it. You just can't see it because it's flat. And then as we age, you might start getting a broad because it's a little bit more obvious because of the separation. And then it can turn into a focal. And it remains for the vitreomacular adhesion, whether it's focal or broad, is there really any prognostic ability that's out there? So vitreomacular adhesions, you can call them focal, you can call them broad, but it doesn't really matter in a sense. When you start getting over to vitreomacular tractions, then the ones that are focal are the ones that can lead into greater issues. So it's the vitreomacular traction, focal versus broad, that you want to watch a little bit closer. So that's why when a patient comes in and I see this and I say, oh, you got a vitreomacular traction, oh, it's a focal, I don't say, I'll come back in a year, right? I say, oh, I'm going to follow you based on some of the findings. Sometimes it's 2 months, sometimes it's 9 months. But depending on what I'm seeing happening going on, I follow the patient because focal versus broad, depending on what we're seeing here, because you can start getting some changes. So I'm going to show you two here. These are two eyes. This is vitreomacular traction. And which one has better visual prognosis? And Joe, if you can launch that poll, that should be polling question number 2. And there's just 2 answers. It's either A or B. Which one has a better visual prognosis going on here?
And we are launching the poll now. And we have a definitive trend right now.
Great.
We'll give people a few more minutes, a few more moments, I should say. And about 3/4 have said A
That's
and the rest of B.
Yep. So better visual prognosis, better. Maybe I could have done worse, but better is A. Now, these are both focal. Okay, these are both focal. You could use the optic nerve here as kind of your 1,500 microns, and from here to here is definitely spanning. This is more focal in a sense, but so being more focal kind of increases the risk. But if you start coming down here and looking at what's happening to this retina, look at this ellipsoid zone. Look at your external limiting membrane, how it's starting to become destroyed. You're starting to get a little bit of a split. And then look right here. What happened to that, what a lot of people call that inner segment, right? That's that ellipsoid zone. It's those mitochondria. This acuity and the way this is starting to open up has a lot worse acuity. This one has a better visual prognosis. You could still see here that the ellipsoid zone, the external limiting membrane, is still intact. Now, this is the inner retina, this is the outer retina, and there is a loose association in there of that to split. So this is kind of lamellar separation occurring. It's really not a lamellar hole because you still have this intact, but you're starting to get this kind of lamellar separation of the inner retina to the outer retina. But this would still have a pretty good acuity based on this one down here. This is the worst acuity. This is the better visual prognosis that's out there. So vitreomacular traction focal, right? This is what we're looking for, is kind of, this is almost a vitreomacular adhesion, but then you start getting that little distortion. And this would classify as a retinal macular traction, or vitreomacular traction right here. Obviously, this is an involving PED. So if there wasn't any distortion, then it would be vitreomacular adhesion. You can see here now, remember, this is, if we get out here, this is going to be about 300 microns in this area right here. So you could see that maybe it's attached here, depending on what you want to call it. But from here to here is definitely less than 1,500 microns. And so this would be focal. These ones we want to watch a little bit closer. This is a focal vitreomacular traction. I have this one all labeled. And when I lecture with Joe, I'm going to steal his comment that you always want to pay a little bit extra, Joe, right? You want to pay a little bit extra for the OCT that labels all of this, right? So you don't have to interpret it. So we're kidding when we say that it's out there. Go ahead, Joe.
And that goes with CT and MRI as well. Pay a little bit extra and get the ones where the arrows are there.
Oh, that's it. The arrows, right? The arrows are pointing to where the problem is. Exactly.
Much easier to interpret.
So this, again, is a vitreomacular traction. This would be focal. We'd want to watch this one a little bit closer, but then check this out down here. This is pretty nice. The acuity is going to be pretty good. As you can see here, the external limiting membrane and then the ellipsoid zone is still pretty well intact, or that inner segment of the retina. And so here's another picture of a vitreomacular adhesion. Oh, no, it's not. It's a vitreomacular traction. Patient's going to have a pretty good acuity, but based on, in a sense, this focal vitreomacular traction, I would probably say that I'm going to check this patient back in 4 to 6 months, give them an Amsler grid, make sure everything's okay. And there's a great chance that this one can just release on its own and all that traction goes away. But we do want to follow them to make sure that, they're not turning into anything negative, that we can maybe have to get them to a retinologist for maybe a membrane peel if they're starting to turn into a full thickness macular hole. And again, you can see here how the membrane is kind of still attached here. You have the vitreous separating out, and it's still intact. There's kind of that epiretinal membrane, that posterior vitreous, making that extra glue in there. And this one would be focal. But what I don't like is these mitochondria that are down in here in this ellipsoid zone, this inner segment, are starting to become a little fuzzy. I'm going to watch this one a little closer. So everyone's always asking me, hey, Doc, why is it 6 months for this one and 2 months for that one? I don't like what's happening down here in this, photoreceptor zone, because if this starts to open up, then we need to get them to the retinologist to start doing some type of treatment. And I'll go through here and go through a couple different scans. And as you can see here, this was scan 4. This will be scan 5. And again, I'm not liking what's happening to this area down in here in this focal vitreomacular traction. So we're going to watch this patient a little bit closer than I would some of the other ones. And you can see here, it's really struggling. It's we're really pulling. It's separating off the epiretinal membrane. You have the posterior vitreous. Hopefully this is going to let go. Maybe not. But down in here now, your photoreceptors are not too bad, but you could see just what's happening with this by looking at these different scans that are out there. And then you can go and click through all the scans, and there's all kinds of cubes of data. This is a 6x6 cube of data. There's 3x3. You can turn these things sideways. I mean, you could just spend hours on top of it. And one of the things that I've been working with as the third-party chair, Joe mentioned I have a few hats that I do in organized optometry, is one of the things that I've been working with the insurance companies is trying to get the payment a little bit higher and have them realize that, back in the day when it was a stratus and time domain and they were a little bit higher, and then the utilization went up and they dropped the price. But now we're getting all this types of information. You could spend 10, 15, 20 minutes, a half hour if you're a geek like me, checking these out, turning them, twisting them. So just trying to point out to the insurance companies that maybe we should get those fees raised up a little higher because there's a lot more data now. It's a little bit more robust of a data. So this is, again, just a cool one. Nothing more than I like this one because this right here reminds me, wherever you want to take it, from here to here is 1,500 microns in a sense. Well, this is definitely a lot less than this. So this is just a focal vitreomacular traction. Not too much going on down in this area, no lamellar separation. This might be a 6-month follow-up, maybe an 8-month follow-up, depending on how long it's been going on. And there's a chance that this can leave on its own, or it can turn into a lamellar hole, or it can turn into a full thickness macular hole. But just wanted to kind of give you some of the terminology out there: vitreomacular adhesion versus vitreomacular traction, focal and broad. So the transition now, I started getting these letters and I started talking to the retinologist because I'm a 1995 graduated, worked at PCO, worked under Dr. Deglin, learned about stage 1, stage 2, stage 3 macular holes. And then, they kind of changed up a little bit of the nomenclature that's out there, where a full thickness macular hole is defined as a foveal lesion with interruption of all layers from the internal limiting membrane to the retinal pigmented epithelium. So nothing really too much has changed in a sense. You could call a stage 1 an impending hole. That was what we had back in the day, right? Stage 1A, stage 1A, stage 1B, impending macular hole. That's in a sense now just a vitreomacular traction, right? And then stage 2, the hole is open, right? And we used to always measure, but it's a smaller medium full thickness where it goes all the way down through, and then a large hole, and then a large hole with a full thickness macular hole with a PVD. So sometimes you'll hear them just refer. They don't really call them stage 1, stage 2, stage 3. You get the letter back, and they're just saying, yeah, it's a medium full thickness macular hole with vitreomacular traction, or it's a medium with vitreomacular traction, or it's a large hole without vitreomacular traction. So I'm just trying to help you out as, all of a sudden I start getting these letters. Well, help me out. Does that mean if it's stage 2 or stage 3? Then someone brought light of this paper to me, a few years ago. And depending on the retinologist, right? There's a retina group that's by me. And sometimes the founder of the retina group, he'll call it a stage 3 macular hole. And the next guy that comes in that was been with the practice for 3 or 4 years is calling it a large full thickness macular hole with vitreomacular traction. So it's just kind of the same nomenclature, just 2 different ways of calling it. And I just wanted to point that out tonight. So how do you get the sizes? Well, it's just based on, whether it's 250 microns or smaller, that would be a small hole. Anything from 250 to 400 is a medium, and anything above 400 is a large hole. And then you start again with the presence or absence of the vitreomacular traction that's occurring with these patients. So, this is a full thickness macular hole, large, without VMT, right? So you can see the whole posterior vitreous is pulled away here. I can drop a caliper in here But, we know from looking at retinas all day long that if we would measure this is probably 500, 600 microns wide. So, and it's from the kind of the narrowest point. You don't go down here where it's really wide. You go from its narrowest aperture. You could drop a pair of calipers in here, measure this out, and you say, oh, it's about 400. And then so it's a large, full thickness look, everything all the way down to the RPE. And then you can even see that the windows open up, that you're getting some hyperfluorescence down into the choroid, which would be kind of a hyper-reflective column, kind of telling you that that the RPE is kind of being diseased there. Maybe it's there a little bit longer, blocked because you're able to see, getting that coherent light down through there. But 400 microns and without a vitreomacular traction. And this one here would be a small, full thickness macular hole without vitreomacular traction. Drop a pair of calipers in here, again, from the narrowest aperture. And when you would measure that, you would, be less than 250 microns. So when you get the letter back, it says, oh, this is a small, full thickness macular hole without a vitreomacular traction, right? So that's how that kind of nomenclature works. So with polling question number 3 here, Joe, this was kind of, I grew up on stage zeros, and then there's impending macular holes out there. So this is just kind of bringing light to, the other eye has a full thickness macular hole. For the eye that I'm referring to now, the other eye, so one eye has a full thickness macular hole. You're going to scan the other eye, and you find a little bit of traction over there. Do you prefer to call that a stage 0 macular hole, or are we calling that an impending macular hole? Just kind of want to see where the audience is, and there's no right or wrong answer here.
Okay, we've launched the poll. Everybody's working on it.
And again, there's no answer, no right, or there is an answer because you're going to pick A or B, but there is no right or wrong answer on this. So where's it trending, Joe?
It's trending slightly above impending macular hole.
Great. All right, so let's move on. So where am I going with this here? So what about the other eye? So what do patients, what do they want to know? They just came in, have a tough time seeing, it's all distorted. You run your OCT and you say, hey, you have a full thickness macular hole. It's small, medium, large, with VMT, so on and so forth, right? And now you're going to have to go for surgery. They'll take that out, take the stress out, hopefully get that hole closed, put a gas bubble in, depending on your surgeon. It's days to weeks to face down. So what's going to be our next question, right? Okay, this happened to my one eye. What's the chance of it happening to my other eye? Well, you really can't answer it. And all the literature that I have read, you really can't answer it by saying, well, you had it happen to one eye, so it's most likely going to happen to the other, or looking at it with a 78 or 90. You need to run an OCT. And when you run the OCT, back in the day, if they had a little bit of traction or VMA, vitreomacular adhesion, or traction, they referred to that as a stage 0 macular hole. But now, anytime you have any type of adhesion or traction based upon the hole being in the other eye, you'll see that the retinologist will just not call it stage 0 anymore. They'll just call it an impending macular hole. Now, as you see here, they're very clear then to point out, now, I just told you had a full thickness macular hole. Now you're telling me I have an impending hole, and that sounds pretty bad. Well, that's good because that's going to keep them from coming in for follow-ups. But as we know, they still have the ability to spontaneously resolve. So you got to be careful with that, even with stage 0 macular hole. Stage 0 sounded good because, hey, it's 0. But impending sounds like it's happening, which is, okay, good because they're going to come in for their follow-ups. But anytime there's any types of traction or even vitreomacular adhesion to that other eye, you still want to call it an impending macular hole. So,
Greg, if I can jump in.
Yeah, absolutely. It gives me a break and a chance to take a breath. Please.
I think if you gave me the choice as to what I would want to have, what I prefer in the other eye is a PVD. Once you've had the PVD in the other eye, the risk is really, correct me if I'm wrong, it should be a lot lower.
Yes. So if you have traction, let's just say that this is the traction that we're looking at on this slide. If you have VMA or VMT and you're calling it impending macular hole, it's up to 47%. That's the highest I found in the literature, is you have a 47% chance. Once you get the PVD, 0 to 3% chance. So yes, it dramatically drops. So once you get that PVD, I'm kind of along the lines of you, Joe, that it's 0. But in the literature, I've seen them quote as high as 3. Maybe there's some type of other kind of mechanism that happens that they still are not out of the woods. But man, when they get that PVD, they're out of the woods. Good point. So let me ask I should have made this a polling question. Ask yourself, is this a macular hole? And go by the definition that's out there for it. It needs to be what? There is definitely maybe a hole here. It's maybe hard to see. Maybe there is some tissue. But as we drill down through, we still have some area of tissue here. Remember, it has to go all the way to the RPE. So this is not a macular hole. This is now a lamellar hole. This is basically the inner retina, which is right here, and the outer retina, which has that loose adhesion. It's being pulled up. It's a little tug of war, and you're starting to get a little separation. And you're getting this, as you read through here, this irregular foveal contour. See, the foveal contour is becoming irregular, and deflected inner fovea, and interretinal splitting, or the schisis. You can kind of see how this is starting to split. This is the schisis that's starting to occur. But you still have the maintenance of an intact photoreceptor layer. When that photoreceptor layer down through here, remember, this is the external limiting membrane, and then we have the ellipsoid zone in the outer segment in the RPE. Your intact photoreceptor layer and the schisis and all this other qualifications here lead us into that this is a lamellar hole that has formed. So this is not a full thickness. You wouldn't measure this and say, oh, that looks like about 300 microns right there. That's a medium full thickness macular hole. That is not. The key here is you have intact photoreceptor layer, which now turns it into a lamellar hole. So, and these, it's been really cool looking at these, that you have to look at the cubes of data. This here is maybe a raster scan with a bunch of lines. You can take cubes of data and do a 3x3 scan, a 6x6 scan. And really, you kind of have to look at all the different scans, because you'd look at this scan here and maybe call it something else. And then you come over here and you could just see that this is just a lamellar hole. When you look at put all these scans together and look at all 21 scans and all the different scans that are out there, you could see here's the foveal separation of that schisis. You're getting the schisis here, and you can still see some of the retinal structures trying to connect that inner retina to that outer retina, but that photoreceptor layer is intact. So even though this looks like a macular hole, this is a lamellar hole by definition, and obviously a much better prognosis than a full thickness macular hole. And the tug of war on this epiretinal membrane is kind of, in a sense, kind of pulling this. You have the traction going this way, creating that separation, that schisis from that inner retina of the outer retina, but those photoreceptors are intact. And in all of these scans here, these patients would have pretty good acuity. I'd say maybe 20/20 minus in this patient. And up here again, looking at where maybe the fovea is in one of these scans is again 20/20, 20/25. And this scan here, everywhere from external limiting membrane to the ellipsoid zone to the or that RPE layer, all intact. 20/20, 20/25 would be would be the worst that I would call this patient. Again, not a small or medium. We can measure this. It wouldn't be a full thickness macular hole because those layers of the photoreceptor are intact. And this is one example of, someone posted this, I think on that OCT Connect. And so I just pulled out my my pen the one day on my iPad, and I have no financial interest in iPads or Apple. Here's the epiretinal membrane. It's the traction. Here's your inner retina, your outer retina. There's the schisis, your intact photoreceptor integrity line, your inner and outer retina split, and then your epiretinal membrane. So again, this is how you want to buy these instruments. You pay a little extra price that hopefully they get all these little colors on there. So now, what about a pseudo hole? Where does that come into play? So what is important here in reading the paper that's out there is that there's no loss of foveal tissue as observed by your typical lamellar hole or your full thickness macular hole. And then you're getting an invagination or heaped foveal edges. You have the concomitant epiretinal membrane with a central opening. And really the key to these is kind of that steepening macular contour to the central fovea with near normal central foveal thickness. And no loss, the key is no loss of retinal tissue. And that's kind of how you start looking at the at pseudo holes. And that's exactly what's happening here. So remember, you got that heaping of the foveal edge, you have an epiretinal membrane, you got that steep contour, and again, there's no tissue. You can kind of see how this tissue is kind of heaping up, and you're losing that contour of this, and no tissues being lost. The photoreceptors are all intact. Again, another probably great acuity, but in this case here, this would just be labeled as a pseudo. It's not a lamellar. It's not a full thickness. Maybe some traction here. Maybe it looks like it's released. So just a pseudo hole is how you would label this person here. And again, here I have it all labeled up, early. And that's kind of cool when you look at this one here. You're starting to get some early separation of the inner and outer retina, but this is still intact. So you really wouldn't want to call that a lamellar hole. You kind of have to have that schisis, right? It's getting there, but it's really not a schisis yet. So again, you're getting that lamellar type of shape, but it has to separate out a little bit more. So let's see how we're doing. I'm not going to do, I don't think any, oh yeah, here we go. I do have a polling question. So Joe, polling question number 4. I think we all have learned, and you can see here that maybe this one's been here a little bit longer, that we have a full thickness macular hole. We can measure this, and maybe that's a small or a medium full thickness macular hole, but this is a full thickness macular hole with what else going on? So if you can launch polling question number 4, kind of want to see how we're doing out there.
It is launched. Pseudo hole, ERM, lamellar hole with separation, or macular pucker are our choices. It looks like we have a strong contingent for lamellar hole separation.
Yay, all right. So that's exactly what's going on. So the terminology would be here. Let's just pretend I measured this here. This is probably greater than 250 microns. It's less than 400. This would be a medium, full thickness macular hole without vitreomacular traction with a lamellar separation going on. So, the surgeon, that's probably, if you sent that to the retinologist, that would be a great way to send it over and tell them what's going on. And then if you go through some different scans, you'd probably find where there's maybe a little bit of an epiretinal membrane kind of pulling that up, and that's what the surgeon would peel during the surgery and release that traction, close that hole. The one concern I have is how long has this been here? You're going to get some hyperreflective light, but remember the RPE absorbs most of that energy, and that hyperreflective column that we see in macular degeneration, what we're seeing here, is a little concern of how long has that been there and what type of acuity will we get back, because the RPE is the life support of those photoreceptors. So yeah, definitely want to get that over there pretty quickly and get that patient treated for their, for their full thickness macular hole and without vitreomacular traction with a lamellar separation or lamellar hole. So let's take a look at this one. What does everyone see here? And it's not a polling question, so I'm just going to give everyone a chance, and I'll kind of walk you through it. I see a little bit of a vitreomacular adhesion. And then I go, oh, vitreomacular adhesion, there's supposed to be no tissue disturbance. And then when I looked at it a little bit closer, I said, I don't like this tissue disturbance. And this patient's acuity might have been 20/20 minus 20/25. And just kind of looking at a lot of OCTs over the years, I said, you know what, this doesn't look too bad. Vitreomacular adhesion, nope, I'm going to call this a vitreomacular traction based upon this patient's morphology change, the retina change, vitreomacular traction. And now what type is it? Broader focal. It's now focal. I don't like that. I'm going to see you back. It doesn't look bad, patient. I'm going to see you back a little bit sooner. And then look what happened 8 weeks later. Whoever would have thought that that little thing right there would turn into this now? What do we call this? This is less than 250 microns. It's all the way down to the bottom. So this is a full thickness macular hole with vitreomacular traction. And this is really cool that we caught it this early. And if you see what I'm talking about here, ladies and gentlemen, see how we don't have that hyper-reflective column going down through there? That's great, right? This is awesome. We did what we were supposed to do, caught it early, and this patient had great visual acuity recovery because we were able to catch it so soon. And it was just kind of maybe dumb luck on my part, me being a geek, teaching these things all the time, always looking at OCTs. I just didn't like what was happening here. And so I brought him back, and we caught that right there pretty early and got them off to the retinologist. So just fun, and that's why I like teaching these here. How about this one here, 30-year-old coming in? I think this one just came in saying, hey, I just need my contact lenses updated. Can you get that for me and get it out? And she opted for the wellness program and take a look here. Man, everything looks good. And wow, 30 years old, what you got going on over here? And, there's a lot of traction, but her photoreceptors were intact, no really cysts. Pointed it out to her, and she said, yeah, if I cross one eye versus the other, I do see a little bit of distortion or blur or whatever she would call it, that there was a difference between the two eyes. And so we decided to follow her back. Do I have her follow up? Yeah, she cleared up nicely. This is her right here. I was hoping that I had the follow up. So this, again, focal, right? We got to be careful with them. Here's another, focal, but everything's intact. Again, here, this is how you can measure. This is how you can tell it's focal. You kind of want to go parallel. When you read the paper, it will say try and stay parallel. Obviously, if you kind of go like this, you want to kind of be parallel to the retina here. So that's why it's kind of tilted, going parallel to this plane. And I measured this here at 455 microns, well below that 1500 microns. The photoreceptors are intact. The external limiting membrane's getting a little fuzzy. So I just said, come on back, see how you're doing. And, she lucked out. Look what she did. She released. And, kind of, here she is before. Look, here's the before. I'm not doing any sleight of hand and showing you someone else's OCT. Here she is before. You could see it up here. And then this is afterwards. And look how that foveal pit just returned. And, just luckily, and how about a 30-year-old? I would expect these to be a lot older. This is March 17th, 2020, this year, right? COVID, right? I mean, first day of COVID, maybe, and in Pennsylvania here, it was all kind of hitting. And so I just said to her to come back, a couple months later, and she did. And luckily it released. So that was a fun case to have. All right, and this was February 15th, 2020. Again, you can go down here and measure it. You can see 495 microns, focal. We want to watch that a little closer on this patient. We take a look at the other eye. Looks like she has a pseudo hole. It's a little distorted, a little heaping up, no loss of tissue. vitreomacular traction in one eye, pseudo hole in the other eye. And you can see right here the culprits, PVDs, in both eyes, PVD. So that, again, that traction, PVD pulling away, releases those astrocytes, glial cells, and as Joe pointed out, some of those RPE cells and how they get up there. And again, look at this, a release and back. Now we still have a little pseudo hole going on over here. You can see the distorted area, but this one here, this vitreomacular traction, released, and you can see the fluid and some of the photoreceptors becoming involved down here. And then that one released, and fluid went away, and the foveal pit went back to normal. So these have been, were pretty fun to follow in the practice. Take a look at this one. Ask yourself, okay, the right eye looks good. Take a look at this eye here. It's not all the way down. It's not all the way down to the RPE. So there's tissue involved. You're getting that schisis. So this here is a lamellar hole, right? This is a lamellar macular hole, LMH, a lamellar macular hole. So this is not a full thickness. You can see the schisis that's occurring here on this patient. And when you look here, you can see the PVD, and you can just, again, see some more, just some different images of what this lamellar hole looks like. And just another photo of that. So are you tired of macular scans out there now? So with that being said, let's jump into retinal angiography. And then what I do want to do is kind of be aware and get to the end, and just, even if I didn't get through all the slides, I kind of want to show you how to look for Plaquenil toxicity. Some people call that a unicorn. Hey, I hear about it, but I never really see it. I work right down the road from a rheumatology practice. We pick up Plaquenil toxicity quite a bit. Now the pearl is are they being really, really well managed, and we can monitor them, because not every case of Plaquenil toxicity do we stop. We'll monitor them, and if it looks to be pretty aggressive, then we'll stop it. So we got to talk about angiography here, and then we're going to talk about some Plaquenil. So Joe, the reason why I said that is help me keep eye on that time. And with that being said, can we launch poll number 5?
It is launched.
And basically it's OCT retinal angiography. Does it require an injection of dye, or it does not require an injection of dye or any type of injection?
I think we're pretty much done, and the vast majority said it correctly. It does not require dye or an injection. That
is correct. So OCT, retinal angiography, you're going to see some really cool images here. It's kind of a new approach. It's non-invasive, again, not needing a dye. And the reason why I keep bringing this up is I can't tell how many times we do a live event, and I go through a whole hour lecture, 2 hours, how to interpret this. And we're standing out, which is cool. And that's why I like hanging out by the coffee machine or down at the bar at night, and people come up and go, hey, what type of dye are they using for that? And I go, there's no dye. How it works is the OCT on these new instruments. So you heard me talk about time domain, and then there was spectral domain. The early generation spectral domain, they scanned at about 30,000 scans per second. 1,000, 30,000 scans. These newer generations, 1,000, 70,000 scans per second. 70,000. And if the patient holds their eyes still, and by using all the kind of the programming that's in the instrument, they're able to subtract out what's moving, and then the only thing that's moving is blood. So if you get a really, really good signal, you can get some really cool images and help solve some images that are out there. And again, I'm going to go back and say, I really can't practice and do really good diabetes care and macular degeneration care now without having the angiography. So if you're one of those 60% in here that have OCT, and that was the 60% number that said they didn't have angiography, you're probably going to want to migrate into that at some point. And I think there was like 17% that said that they have angiography. So hopefully these few of these images will help you out. Now, no dye needed. We kind of pointed it out earlier. You're kind of getting that superficial plexus, deep plexus. This is kind of your diabetes range, right? And then over here is your macular degeneration, where you're in your outer retina and your choriocapillaris. And we saw these earlier, so I'll go through them quicker. I always like starting looking at the choriocapillaris, coming up, making sure it's a sea of white, then a sea of black, because there should be no photoreceptors there, and that, or no blood vessels there. It's all photoreceptors, sorry. Should be all photoreceptors, just no blood vessels. Deep capillary plexus, and then the superficial plexus. And this is what's really, really been cool with macular degeneration. Take a look at this B scan that's down here. This is just really sick RPE. You can see the intermediate to large drusen. You can see these hyper-reflective columns. You look at the RPE. The vision in this eye is really good. How many of you out there, raise your hand, I know I can't see it, but raise your hand, would say, hey, there's a choroidal neovascular membrane there. And there is, and you can see it beautifully right here in this choroidal picture. It's not, it's not in the outer retina. Sorry, I coughed in your ear, and that was loud. I apologize. But the this photoreceptor area has no blood. This is in the choroid. This is occult. It's below the RPE. This is the deep plexus. Now, if you shoot a fluorescein angiography on this, there is no way that a retinologist is going to see this. Two reasons. One, it's below the RPE. Fluorescein does not see below the RPE. That's ICG, indocyanogreen. The fluorescein angiography would not see it, one, for that, because it's below the RPE. But there's a whole other second reason. And the other reason is it's not leaking, right? So there's been some really cool terminology that has really surfaced due to technology. Maculogics has dark adaptation, which has been around since 2013. The instrument really wasn't the best. They just launched a new instrument this year. So now we're talking about the subclinical, substructural drusen that we can get through dark adaptation. Fluorescein angiography has helped us with this. Occult, non-exudative, right? This is an occult. It's below the RPE. It's not leaking. It's non-oozing. It's non-exudative. Choroidal neovascular membrane. I'm finding these all the time, which is really, really cool. And I've been working with my retinologist that comes into town. From Pittsburgh, they come up to Altoona. My first 3 of these that I sent over, they were like, Greg, we understand that there's a 15.2 times of turning into exudative, but we really don't know what to do with these. You know, your technology is outpaced where the studies are. So we watched them closely, and all 3 in the first 3 to 4 months bled and vision dropped, right? There's a net right here. It's right there, right below, right where those photoreceptors are, and it bleeds, and the vision dropped. The 4th, the 5th, we've been injecting in the practice. I'm not saying that's what your retinologist is going to do, but we had this kind of heart-to-heart, this talk, why not, till we figure it out. Your first 3 or 4 bled. Let's do the next 3 or 4, and we're saving vision because we're picking up on these early choroidal neovascular membranes. And here's another case. Now, this one is not a non-exudative, but you can see the choroidal neovascular membrane here, and this one is leaking, right? You can see that there's fluid. So this is just a type 1, meaning that it's below the RPE. Right here is the photoreceptors. Here is the choroidal neovascular membrane, but it's leaking. So this is just a type 1 occult choroidal neovascular membrane. And how about this one? You have this patient come in. You have drusen, large drusen. This is a very sick RPE. You could see these pigmented epithelial detachments, what we call drusenoid pigmented epithelial detachments. Very large, numerous, maybe in a kind of a hyper reflective foci forming here. But, you know, this fluid maybe, so we decided to run the angiography on this patient. So these drusen here represent this. These drusen here are in this image. Ran the angiography on this patient. I'll show you how I ended up with the fluorescein is because we sent this over to the retinologist, and it's kind of a higher level of interpretation. But I'm going to kind of go through it here because you have to look at a lot of scans. You're just not going to pick it up on tonight. You kind of have to scan through, move it around in this cube data. But as you scan through here, yes, you should have some nice blood flow in the choriocapillaris. The drusen should not be vascularized like this drusen is becoming vascularized here. You can see that the blood is kind of moving up into this area. And there's nothing above it. Sometimes you can get a little reflection down from above. But this looked very suspicious. So we decided to go over and do a 6x6 scan. And look what we could see developing down in this area. There's a choroidal neovascular membrane. Not going to be seen on a fluorescein. It's down below, and it's not leaking. Maybe it is a little bit. Maybe that's fluid right there. So you could call it a occult non-exudative. If you think that's fluid from it, okay, it's an occult exudative. But it's not going to be seen on a fluorescein angiography. But look how we can beautifully pick it up here, and then it's not even in the photoreceptor layer right here. So this has been fun, a little reminder of type 1 choroidal neovascular membranes. They stay out of the foveoavascular zone. They grow underneath the RPE. That's a type 1. And a type 2 is they break through and get into the outer retina. How about this not so obvious one? And this is why I say it complements so well, is you can look at this and just, it looks good. It's macular degeneration. We got a couple bumps right here. And then I decided to take a look at the scan. I didn't like this area right here. I didn't like how this area was lighting up. And look on this 6x6, how we were able to pick up this occult non-exudative choroidal neovascular membrane. And here it is on a 3x3, this vascular area that's occurring. And we just have, examples time and time again. This is an exudative one. You can see the fluid that's occurring, but look how we can beautifully find this down in the choroid. It really hasn't broken into the outer retina yet, and get them off to the retinologist for a scan. Let me show you how this works in diabetes. This has really been fun in diabetes. And really where it's fun is in most of the time, diabetes and using this technology will affect the foveoavascular zone. And how many times would you have looked at this retina, right? I do a lot of diabetic programs in Pennsylvania. I'm working with UPMC, Highmark, Geisinger, and about 5 companies out there, 5 payers out there, getting patients back in and not having to use a fundus camera because it's well beyond diabetic retinopathy and what a camera can pick up. So we want to get them in for the polyneuropathies, mononeuropathies, the early onset of cataract, and getting this type of technology. The foveoavascular zone, right? It's foveoavascular zone. So just outside the foveoavascular zone, theoretically should be the thinnest amount of capillaries. And that's what diabetes is, right? It's a capillary disease. It picks on the capillaries first. That's why we have neuropathy, fingers and toes, nephropathy in our kidneys, retinopathy in our eyes, and we can visualize this retinopathy at the foveoavascular zone. Look at the dropout, and then look right here. Everyone look right here where I'm circling. We're going to put my pointer right on top of it. I'm going to move my pointer away. That's a microaneurysm. So there's really no normal. I don't like this slide. There's no normal number. I'll show you how to interpret these as we go through. This was pretty cool. I did this in the practice, 2015, 16, and 17. This is where you look in the superficial and deep plexus for any type of retinopathy that's going. Right here was the first time we picked up something in that inner to outer retina, right where that zone is, where those capillaries start to leak. Hemorrhage or exudate right here. You can see it wasn't here before. Maybe this is becoming a little bit choppy, some early changes. But look what's happening to the foveoavascular zone, and look what's happening to the capillary density. It's just dropping as it goes by. And our B scan looked pretty good for about 2 years. We were able to pick up diabetic retinopathy at such a higher level. Now, this is how I kind of do it. I don't really look for a normal number. I like scanning the foveoavascular zone. When you hear me talk about how to interpret OCTs, you hear me hammer all the time, symmetry. These should be pretty symmetric. And the number that I use is 0.10. So this is within, so 01, 02, 03, 04, starting to get up around 09. I start scratching my head a little bit. So 0.1, they should be within each other. and this one's O2. So a nice, healthy fovea vascular zone on this patient. Take a look, if we just go down here, 0.35, 0.3, 0.2. There's a 15 difference. Look what's happening. You can see some spots here in this patient with diabetes, but look how nice this B scan looks. The B scan looks great. We're going to dilate this patient. Hey, there's no diabetic retinopathy. I don't see any microaneurysms. I don't see any dot and blot hemorrhages, exudates, IRMA, no 4-2-1 rule. To me, I call those the macro changes of diabetic retinopathy. And now we're getting into the microvascular changes that we can pick up. And it's usually the eye that's bigger that's starting to expand. And look over here now, whenever I blow this up for you in this picture, look at the holes, look at the diabetic retinopathy, and look at the foveolae vascular zone, how there's dropout. And it's starting to be, this patient needs to get their hemoglobin A1C and get serious about their diabetic retinopathy. And again, how many times have you done a dilated fundus exam, looked at the B scan and said, hey, this patient looks great, right? So this has actually been fun in the practice, picking up diabetes relatively early and explaining to the PCPs what's going on with the patient. Here's patient 2 with diabetes, looking at the foveolae vascular zone. Look, here it is. I don't like it. It's 0.10 difference. Let's go look at them. They're both distorted, but disease is usually a little bit asymmetric. So that's the good news. You got to be careful with that. You always got to look at the scans because maybe they're expanding at the same rate and they're not going to be 0.1 difference. In this case, it worked out. But look at the diabetic retinopathy in this eye and look how that foveolae vascular zone is being distorted. Being a geek, look right here. Vitreomacular traction in this eye, right? Vitreomacular adhesion. Oop, it's distorted. Vitreomacular traction. Look at this one. It's kind of hard to see. This would be a broad-based vitreomacular adhesion. This would be a focal vitreomacular traction with diabetic retinopathy in both eyes. And that's how I bill it. I bill it as diabetic retinopathy, and we follow the patient back. Now, we can't really rely on everything that I told you, and that's why I said it complements each other. Look at this. Oh, look, 0.22, 0.20. Oh, within that, well under that range that Caldwell talks about. But when you look here, but I don't like this area. It looks like there's some capillary changes over here. You come over here, it's a little distorted, but it passes the test. But when you come up here, look what you see. In the B scan, now you're starting to see some leakage. Okay, this is a different patient. It's not from the vitreomacular traction or adhesion. This is actually capillary changes that are happening and getting some leaking. Again, these two complement each other. For you to have OCTs out there, probably in these years to come, you'll probably want to start looking at this technology to really complement your patients and their skills. And this is the patient here. Remember now, whenever I looked at this, I said, oh, come on, there's got to be some vascular changes. Oh, yeah, when you look at it underneath and clicking on right here, custom, and I'm looking kind of at a very narrow band through here. You can see what's happening in the B scan. You can see now the capillary changes. It's creating this exudate in this type of blood that's occurring. And again, there's just cases where this has been fun in the practice. Here's another person, a 29-year-old man with diabetes, yearly diabetic exam, reports no changes in vision. Type 1, blood sugar this morning was 190. His hemoglobin A1C is 8.6. Vision is good, anterior segment normal. He does have proliferative diabetic retinopathy, but no clinically significant macular edema. And there's what I billed. It's not really relevant for this. But as what I want to point out is when you do your wide field imaging, yeah, you can see a couple hemorrhages here and there, kind of scattered. Looks like there's on this here, maybe one right here happening. But the retinas don't look too bad. And that was 2017. Go into 2018. Doesn't look like a lot of change going on. But if you're getting those retinal macro changes, that's kind of like, to me, like a notch on a visual field. If the notch is on the visual or on the optic nerve, sorry, not a notch on the visual field, but if you're finding a notch on an optic nerve head or neuroretinal rim, there was GCC and nerve fiber layer loss way before that. And so now we're able to get and take a better look at these patients using B-scan OCT, using OCT angiography. And again, here's just a bigger picture for you. Doesn't look like there was a lot of change going from 2017 to 2018. And again, here's the other eye, and there's some changes going on in type 1, and he's probably had this for many years. Hemoglobin A1C is 8.6. I don't like that. How does the B scan look? Well, a couple questionable areas, like right in this area. It gets a little lumpy and bumpy. Same thing in this area here. Not looking too bad. I'm pretty happy. Take a couple scans of the B scans. Now we got in this area some cystic changes. Got some cystic changes here. So we're showing up on the B scan. Some exudate or hemorrhage right here, blocking that signal. This is not photoreceptor dropout. It's just the signal is not strong enough to pick that up. Down there, scanning across, seeing a little distortions in this patient with diabetes. Now we come up here and we take a look at the scan. Choriocapillaris looks good. The photoreceptors look good. This is not where diabetes is. Diabetes is up here in the superficial and deep plexus. And you can start seeing what's happening here. I don't like it, all these lakes and dropout, distorted, starting to fill in some area. And then when you click exit, click exit here, you can get out of this and you can look at the foveoavascular zone. So that was the right eye. This is the left eye. You can see right here a microaneurysm. You can see dropout in these areas. And again, you click out of exit, and there's a little button drop-down button here that allows you to measure the foveoavascular zone on these patients. And it's right here. It shows up a little bit better. See how I have it turned off? This is the left eye. And right here, I just turned it on. See where it says foveoavascular zone? And it gives me these measurements. And now I can get a really good understanding what's happening here. You can see over here, there's some exudative or blood. You can't tell on an OCT. They both light up as hyper. So you'd have to use your 78 or 90 to see if this is exudate or blood. And then you would look and you see this dropout area right here, that it's becoming distorted. We're picking up and following and managing diabetes at a very, very high level. Look at these microaneurysms right here. Look at the dropout that's occurring. But it's definitely worse in this eye, the right eye, than the left eye when we're measuring that foveoavascular zone. And that's what I used to look at angiographies all the time. When it first came out, I thought it was going to be like Rocky Road ice cream. And it was okay, but it didn't have these measuring tools. Once they got these measuring tools, then it was awesome. You can then follow patients and see how their foveoavascular zone and how it's doing. Is it distorted or not distorted? And here's a 58-year-old woman with diabetes, or a 58-year-old man with diabetes, new patient to the praxis, unsure of the hemoglobin A1C, metformin, glyburide, Invokana, 2020. Just, hey, I'm 58, think everything's good. And I really don't track my blood sugar. I really don't track my hemoglobin A1C. Decide to get the wide field imaging. Starting to look pretty good here. Imagine this going to some primary care doc. Oh, you don't have diabetic retinopathy. Whatever. Do what you want to do with your blood sugar. So we got the patient opted to get the wellness. This all looks pretty good. All looking pretty good. Maybe starting to get a little bit of some vitreomacular adhesion here, some lift off. Come down here and we take a look at the foveoavascular zone. And I said, oh, look at this, 0.09. I'm going to start scratching my head a little bit on this one. This left eye is a little bit bigger than the right eye. Could be just normal. I like to use 0.10. So let's take a look at their foveoavascular zones. So we take a look at their foveoavascular zone. This right eye looks pretty good. Maybe a little dropout occurring. I don't like these kind of thinner areas, and you can measure that with some technology out there. But take a look what's happening to this eye. Right, this we're picking up on diabetic retinopathy at a very early stage. Right. In the days, there's no, dot and blot hemorrhages, no exudate, no IRMA, no neovascularization of the disc or elsewhere. Those are all kind of macro changes. We would probably send to the retinol or to the primary care and endocrinologist. We'd say, oh, look, the patient is 58 years old. We did some dilated fundus exam. We did a wide field imaging. We did some B scans on them. no diabetic retinopathy until you have this technology where you can see that they have diabetic retinopathy. Again, it kind of complements exactly what you're doing with the B-scan type of technology that's out there. With that being said, I know we're getting close to time, and I want to go through the Plaquenil. And so let me just kind of click through here and just kind of show you this case at a rapid pace. I think you've seen enough. This is another patient with diabetes. You can montage them, show them how their capillaries are being damaged, explain to them that it's happening to their eye, it's happening to their fingers, toes, their brain, their heart. There's probably changes going on. You could see the dropout, the microaneurysms. Before they had the way to measure, this is kind of the scans that you had to use. Again, a little tough. You had to get good at it. Thank goodness for the ability to measure that's out there. And again, you can start seeing now what's happening, the dropout on this patient, measuring the foveal avascular zone. Look at that foveal avascular zone on this patient. Look how distorted this is happening. You can see this exudated blood, how it's just kind of matching perfectly with what's happening to this foveal avascular zone. Never a day goes by that we don't have fun being a geek with our angiography in the practice. And again, you can see here microaneurysm formation dropout that's out there, having fun with these patients. So let me talk about Plaquenil toxicity here real quick, with the COVID being out there and Plaquenil and hydroxychloroquine potentially being a part of the treatment, and patients with rheumatoid and, on OCT Connect, people are like, oh yeah, there's no such thing. We talk about it all the time. There's been papers put out. I've never seen it. And I think it's for the fact that, we're not sure where to look for, which scan to use. Is it a B scan now? Is it angiography? I can tell you right now, it's not an angiography. This is not a capillary disease. The pigment, the hydroxychloroquine, the Plaquenil builds up in the RPE, and once it reaches the toxic levels in that kind of parafoveal areas, where you could start kind of getting the tissue becoming atrophied away. So I like this slide here is because this tissue right here is intact. This is the disease tissue in Plaquenil toxicity that's out there. So if you're going to look for Plaquenil toxicity, you kind of want to look in this parafoveal area of the retina. I'm going to go through these slides pretty quickly here. There was for the longest time, there were some recommendations in 2002. Then in 2011, new recommendations came out, and they said, just image them. And if it's the typical dose, 200 milligrams twice a day, it's 1,000 grams, you can see them back in 5 to 7 years. I work closely with the retinology practice. There's obese patients, the Plaquenil builds up. There's underweight patients, and they have to use 400 milligrams twice a day to get that therapeutic dose to treat that rheumatological condition. They can't really weight adjust it. It's like aspirin. If you take aspirin 81 milligrams, it's going to help you with your antiplatelets, it's going to help you with a heart attack, but it's not going to do a darn thing to reduce your fever. So you have to give it at a certain level, 400 milligrams twice a day. 200 milligrams twice a day, 400 milligrams daily, to kind of get that therapeutic, that rheumatology therapeutic dose. Now, Larry Alexander, these are his slides, and as long as they stay relevant, we all probably had Larry Alexander's book. He suddenly passed away, probably 3 or 4 years ago now. But as long as they stay, he gave me these slides, and as long as they stay relevant, I'm going to keep using them in his honor, because he was a great phone a friend. So Plaquenil toxicity, we don't want to see that bullseye. We want to be able to pick it up way before that. And which part of the retina are you looking at? Well, you can use the ganglion cell complex to see if you're getting kind of this ring scotoma. But you're looking out here again in this parafoveal area. That's what Larry kind of always drilled into in teaching, is you can use retinal thickness maps. You can see that this parafoveal area is starting to occur, and that's where you want to look. Because this is crashing kind of down, it looks like this is moving up, and they talk about this flying saucer sign or this top hat appearance because this area is being maintained, but that parafoveal and perifoveal area is starting to drop. And I'll get you to a case of mine here where I'll show you where I have 2 things that I can point out to help interpret and catch these cases relatively early. And these are just all Larry's slides reminding us is this is the area where we want to look for the Plaquenil toxicity, looking for maybe that top hat, that flying saucer. This area is maintained because the atrophy is in that peripheral area. This is the slide that I started off with earlier at the very beginning with all the different areas labeled. Check out how bad this patient's Plaquenil toxicity is. Here's that kind of flying saucer appearance. This area is maintained, but look how even from right here, if you follow that mitochondria, that inner segment, that ellipsoid zone, then it just disappears through here. Just lots of atrophy that has occurred in this right and left eye. This patient was probably put on Plaquenil and just never followed up, never went to the eye doctor. So, once you see this on a retinal photo, the horse is way outside the barn. So let me just show you a case of mine. This is a 71-year-old woman with lupus and hypertension. You can see she's taken a couple medications here. The one that we want to talk about is Plaquenil for 15 years at 400 milligrams. She has some mild cataracts. I diagnosed her in 2013 with Plaquenil toxicity. So she went to her PCP. I talked to the rheumatologist. I said, it's not too bad, but it's, the patient's kind of young, 71. They're having some toxicity. We can watch it. So we created this kind of little confusion. So the PCP said, hey, why don't you go to an ophthalmologist and see what's going on? Well, the ophthalmologist says, well, I respect Greg for what he does, but I really don't see any Plaquenil toxicity. So why don't you just stay on that medication? Patient was being followed got sick and tired of sitting forever in the ophthalmology practice, complained to the rheumatologist. I really like Greg. He explained a lot of stuff, blah, blah, blah. The rheumatologist said, hey, that doesn't really hurt. Why don't you jump over and get another opinion? So I didn't see her for 3 years. So she comes back, and here are her pictures. No bullseye, maculopathy. Everything looks good here on the autofluorescent type of testing here. But here's where she was in 2013. And here is the 2016 scan. Now, remember, it's in this area right here is where you want to look. And so this scan right here is representing like this area here. That's kind of hard to see that. So what I like to do is I like to look at this scan here. But already take a look at this, ladies and gentlemen. Look at this. Already 16 microns, 18 microns, 14 microns, and 16 microns over the course of 3 years. Now what I'm going to do is I'm going to kind of scan down through here. And I'm going to stop, as you see right where I am at this scan. See, I'm cutting through here. It's this area out here that you want to try and pick up the Plaquenil toxicity. Look at her scan up here in 2013. Here, see how you can follow this outer nuclear layer? And all of a sudden, it looks like it's starting to become a little bit absent. And look right here. Look how this is kind of dropping down. Remember that Plaquenil builds up in the RPE at high toxicity, and then it starts to whatever the process is of the toxicity on the outer retina, and it starts to come crashing down. 2013, Greg said that you have Plaquenil. We can watch it. It doesn't look too bad. We'll see how advanced it is. She's kind of young, so on and so forth. But look what happened in 2016. It's a little bit more obvious. There's two ways I'm going to tell you. You want to look in this area, but look at the contour. I'm trying to work with the designers of these OCTs for Plaquenil toxicity. You see, you got this kind of, I'm going to over-exaggerate. It's high, and it's low, and it comes back up. If this is crashing down, can we just kind of take the retinal contour? Now, I understand that there's epiretinal membranes, vitreomacular traction that can distort that, but look how flat this looks here, and it's even a little bit more obvious on the left eye. See how we're kind of losing this up here? Well, if this is changing down here, this is kind of flattening. So just look at the contour here and the contour here, and we definitely can see at least the photoreceptors are intact. And right here, we're starting to get a little concerned about the photoreceptors and this nuclear layer. This here is we finally decided to change this for this patient so they didn't end up and they switched to a different medication. That's the right eye. Let me show you the left eye. Again, see this cut right here? You'd have to look in this area. It's a little tough. You want to get down here, right through that macula. So I'm just going to kind of scan through. I have all the scans in here. Take a look. We picked up the changes in this area, and right through here in 2013, she came back 3 years later. She's definitely more obvious. She's got that kind of flying saucer appearance. Look how this area is kind of flattened out. Look how nice it goes up and down and up. Early Plaquenil toxicity, definitely Plaquenil toxicity. 19 micron change, 16 micron change, 20 micron change, and 17 micron change. That's a lot of microns in a retina that's that's thin to begin with. So there's how you pick up Plaquenil toxicity that's out there in the retina, or in patients with Plaquenil having the toxicity using your OCT.
Greg, we had a few questions, if you don't mind. Are you ready for it? In regards to your wellness program, do you have patients pay more for a macular OCT?
I don't. With regarding the wellness program, we basically just offer two levels. It's basically Optos and the kind of just the regular B scan, and then we add a level of angiography. So most patients get the what we call the triple O, the Optos, the OCT and OCT A. So we kind of offer Optos and OCT B scan, and then they add in the angiography. What we thought of was that maybe the patients with diabetes or a little bit older, but COVID has turned everyone into kind of being wellness geeks. They track their steps, they're doing more wellness. The 28-year-old that jogs marathons, they want to see what their vasculature looks like. So pretty much what patients do is they go for the triple O's, what we call it. We do have two separate prices. So the answer is yes. We charge $50 for the double package and $70 for the other. I understand that there's a lot of people listening. We're not price fixating out there, so I can talk about prices. I'm not telling you what to charge. So to answer your question, we do charge a little bit more for the angiography.
Greg, are you finding these subtle findings in patients who are paid for the wellness program? Because they look fine until you look. So it's hard to substantiate the scan in the first place. Explain that.
Well, it's a wellness scan, so the patient actually pays for that out of their pocket. So we offer that when the patient comes in, just like most offices are very familiar with Optomaps. We just add the OCT wellness scan, B scan, and then the angiography to the patient. Now, being a third-party chair for Pennsylvania, I will tell you that if you find something, you just don't say, oh, now we're going to bill it as diabetic retinopathy. The patient had a wellness scan, so they pay for the wellness visit. So we just run wellness on patients, and it's a cash pay, and it doesn't get billed to the insurance. It's something that the patient the patient pays for. If you find something, and that's the whole idea of wellness, you tell the patient, hey, look, you had this done today. I found a vitreomacular traction. We found this. I'm not billing your medical insurance. This is you opted in for this. You're going to pay for that. I'm going to see you back in 2 months, 3 months, a year, 6 months, whatever you decide. And at that point, you can now, you have a diagnosis, and you can use your 92133, 92134, 92132, which is anterior segment, to then bill the patient and use the appropriate ICD-10 code. But we're not flipping anyone. And then the other comment that I'll make on that, Joe, is I'll have patients come up to me and say, or doctors come up to me and say, well, I do it all the time. Well, I drive 70 and a 55, and someday I'm going to get nailed on it. But so I just want to make sure everyone knows what the rule is. You do what you want. I'm just making sure you know what the rules are.
Greg, when there's no hemorrhages, but there is capillary changes or are capillary changes, what do you specifically code it as?
So pretty easy in a sense. I don't want to make it like the question is, but I went through the same struggle. That's why I kind of paused. What is it? It's diabetic retinopathy, right? So I bill it as minimal or mild non-proliferative diabetic retinopathy. What is minimal? It's microaneurysm changes. So it's, you don't see them on a 78 or a 90. It's mild or minimal non-proliferative diabetic retinopathy without diabetic macular edema. And you follow them back, and you just follow them at that. I built a lot of diabetic programs in Pennsylvania with insurance companies because they want their STAR score and their HEDIS score. STAR score to go up for the Medicare Advantage patients and the HEDIS score on the commercial patients. They primary care docs, they get paid by different percentages of the levels of hemoglobin. Why do you think that they're doing these things in their office, right? If someone comes in above a 9 and they get them below an 8, they get an incentive. They get them below a 7, they get an incentive. Why aren't we? We're helping them. I'm finding all these changes. So we've done some pretty fancy things out there. And where I'm going with this, everyone, ladies and gentlemen, that's where I'm going with this kind of soapbox is that I've had these talks with the billers, the payers, right? The big companies. And I say, look, I have this technology here and it's diabetic retinopathy. Yeah, bill it as diabetic retinopathy. That's what it is. It's just that the technology is finding it, not your dilated exam. So it's diabetic retinopathy. You're not billing dead people, Greg. You're using technology at a high level. You're showing me foveal avascular zone changes. It's minimal to mild. It's not severe. So you're not going to see the patient back every 2 months, but you're going to see the patient back and coach them appropriately and really help get the PCP and their hemoglobin A1C down. Good questions. Great.
And we have one final question. Does your OCT-A have blood flow analytics?
Mine does, yes. Yeah, my OCT-A does. So not all of them do. So my pearl out there would be to, I'm not here to sell any company, bash any company, so on and so forth. I did angiography for now 3 years. I worked without angiolytics and I worked with it. I can tell you having something to measure will help you. You'll appreciate it a lot better, but just do all your research. I'm not sure what the changes are now in October of 2020 where the other companies are.
I think that's it, Greg.
All right, perfect. With that being said, I'm going to transition. I want to thank everyone for showing up tonight, and I hope you learned something, and I hope you become more geeky like I am with OCT. And for those out there that are the 17% with angiography, hope you got a little bit of something out of that, and hopefully the 60% that have it will consider it. And then there was about a 25% that maybe this is something that you'll put into your practice, or maybe you don't have to because it's just not your practice modality. But when you get the OCTs and you hear people talk about them or review them, you'll have a better understanding on how to interpret them. So that ends the CE program.